Now we will talk in anesthesia, about anesthesia and surgery during siege conditions. And I call Dr. Ahmed Al-Ghubashi. Dr. Ahmed Al-Ghubashi is a consultant, senior consultant of Anesthesia South Africa, to chair this part of the session about anesthesia. And then after this, we will have usually anesthetists and surgeons are partners in everything. So we are making such a partnership in this session as well. So Dr. Ahmed, please take the first part as a chairperson. And after this, Professor Fahim Basyouni will share the second part. So Dr. Ahmed, the microphone is yours, please.
Assalamu alaikum. I greet you with the greetings of Islam. Peace be upon you all, my colleagues, brothers and sisters. It's an honor to participate in this program, in this conference, and I hope it will be fruitful and useful to our brothers and sisters in Palestine, in Gaza especially, and beyond, as it looks like the region is going to have these problems now and again. I briefly am a consultant in Edenville Regional Hospital in Johannesburg, South Africa. Originally from Egypt, graduated from Alexandria University. I had the privilege of joining Gift of the Givers with one of the missions to Gaza in 2014, and before that in Syria in 2013. And I saw firsthand what the conditions, the restrained conditions and the limited conditions they're working under, and the strain it puts on them in terms of emotional and professional restraint. So I hope, inshallah, this conference will be something that they can make use of, and beyond this conflict, hopefully it ends soon, inshallah. I have the privilege now in introducing Professor Dr. Yaser Tolba. He's a consultant critical care medicine and anesthesiology, medical director of surgical intensive care, associate professor in the College of Medicine, Al Faisal University in the Kingdom of Saudi Arabia. Professor Yaser, the microphone is yours.
Assalamu alaikum. I'm trying to share my screen. Is it?
Yes.
I'll just go to. Okay, is it now? We can see the screen. Good.
Yes,
you can see my slides, yeah?
Yes, Bismillah.
Okay, Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Professor Ahmed, for the nice introduction. Thank you, Dr. Muhammad Yusuf and Professor Muhammad Yusuf for the invitation. I'm going to talk today about two important subjects in anesthesia. First, about general anesthesia under siege, tips and tricks, and also I'm going to talk, followed by my next lecture was about regional anesthesia. And I'm trying to, inshallah, the intention is for the sake of Allah subhanahu wa ta'ala. So I'm trying to, I'm not, because it's a big subject, I'm not going to talk about the whole anesthesia, but I'm going to select what is important in this kind of difficult situations. Alhamdulillah, I have the privilege from Allah subhanahu wa ta'ala that I've been to different parts of the world, under the deprived part of the world, like in Africa and in Asia, and I've seen these things. So I'm talking about experience as well, alhamdulillah. Anyway, so start, as always, we start with ABC. So I'm going to start with the airway first, because as anesthesiologists, we are the one who look after airway. So about emergency airway, it is not like an elective airway. So the emergency airway management usually resulted in high incidence of difficulty. For example, an elective airway, like we do in a normal situation, in a patient who's coming for an elective procedure, the incidence of difficulty is less than 1%. But in emergency situation, difficult airway can up 10 times more, so about 10%. Also, severe hypotension can happen, severe hypoxemia can happen, even cardiac arrest can happen. So we are dealing with a different kind of airway management in emergencies. So you have to put this in mind. And this is just, for example, I just go to show you, this is the normal airway when we do intubation in normal condition. But this is an emergency patient. You can see how much anatomy is different. You can see here the vocal cords we cannot see very well. There's a lot of edema. Just to give you one example. So just to make you aware about the difficulty we can face in emergency airway management. So now we go to the basics, how to open airway. This is a very important skill. Even if you are not an anesthesiologist, you need to learn this. Even if you're a surgeon or any other specialty, you need to learn this because you can save lives by just opening the airway. Because if you open the airway, you allow oxygen to come to the lungs and they save the life of the patient. Of course, in an unconscious patient. Then after you open the airway, how to do bag and mask. And the most important thing is the oxygenation, because even if you cannot insert an endotracheal tube, at least keep oxygenating the patient, keep bagging the patient. That's the most important. And you need to know your anatomy. So this is the anatomy of the airway. You can see here, this is the mouth. You can see this is the tongue. And when you have an unconscious patient like this in this picture, the tongue will touch the back of the throat and close the airway. So your mission is to move that back of the tongue away from the throat. How we do this? Either by a maneuver called jaw thrust. So we put our fingers in the angle of the mandible and get the lower mandible above the upper mandible. That's a very important procedure. In this, we don't move the neck if you have a trauma patient. So if you have a trauma patient or cervical spine injury, we don't move the neck. So the neck will be in neutral position. We just move the mandible. In other situations, when you don't have a head injury, you do chin head tilt, chin lift, and you same idea. You try to push the mandible away like this in order to avoid and pass it beyond the upper teeth, so you can move the back of the tongue away from the back of the throat. And the reason for the head tilt is to get the axis. So the mouth axis will be more aligned with the laryngeal axis, so a patient will breathe better. This is how to position. As I told you, this is the sniffing position. This is the head tilt and chin lift, and this is like a morning sniffing position. And as I told you, this is in the neutral position. You have the oral axis coming perpendicular to the laryngeal axis. But when you do the sniffing position, you're actually aligning the laryngeal and pharyngeal and oral axis. Then after that, you do bag and mask. So you open the airway. This is number one. Number two, you have to ventilate this patient by do bag and mask. This is basic. So this is a face mask and this ambo bag. And this ambo bag is a self-inflating bag. You can do it with one hand if you are alone, one person. So you do C and E. So you put your 4 fingers around the face of the patient, and the C is your thumb and first finger around the mask to make a good seal. And with the other hand, you ventilate with a self-inflating bag. And when you do this, you connect this to oxygen as well. If you have another person, you can put both hands to make a good seal, and the other person, so we have the C and E with both of your hands, and somebody will inflate the patient for you. Sometimes you need an airway adjuncts. The whole idea as well is to move the back of the tongue away. So you put the oral pharyngeal airway. This is the oral pharyngeal airway. Sometimes in England they call it Guedel airway. Or you can put a nasal airway. And somebody will ask me, can I put both together? Yes, you can put both nasal and pharyngeal and nasopharyngeal. This is both of them can help to open up the airway. This is the anatomy of the larynx. And this is from the back. So I'm now standing behind the back, and you can see here, this is the back of the tongue. This is the epiglottis. And you can see here the opening of the larynx, and this is the 2 vocal folds. And this is the arytenoids, and this is the corneoid cartilages. So this is our tube will go between the vocal cords here. This is how we do intubation. So we go with our left hand. We'll carry the laryngoscope in our left hand. We'll go from the right side of the mouth of the patient and push the tongue aside. Then and you can see here, once you see the epiglottis here, this is when you see the epiglottis, you go here between the epiglottis and the tongue in a space called the vallecula. and you lift up the epiglottis. When you lift up the epiglottis, you can see both vocal cords, and when you do this, you can insert your tube. This is when you insert the tube, and tube now in position, and you can see here the tube here, and you can see here the cuff of the tube, inflate the cuff of the tube to secure the airway and prevent aspiration. Video laryngoscope. Video laryngoscope is now the modern way of doing it. You know, here you see here, this is the manual laryngoscope or we call it Macintosh in this picture, but in here we use video laryngoscope. This is the standard now in especially of non-anesthesiologists who are not dealing with airway on a regular basis. There's evidence to show that gyroscope or video laryngoscope increase the chances of their first attempt intubation. But in this, of course, in these difficult areas where this is a luxury to find some gyroscope in a disastrous area. So I'm just showing you the picture, but you know, but I don't expect this to happen in Gaza or anywhere. But just to show you the picture. But what we can have if we travel to Gaza is to buy this. This is we can buy this. This is a handheld, battery operated, and this we can use video. It's a video laryngoscope, but you can carry in the hand. And I advise anyone. So if I go, inshallah, I will have one of them. And this is also another one. So in order to assess the airway, you need to differentiate between difficult intubation, which is inability to intubate within 3 attempts, or difficult to ventilate and oxygenate. What is more important is difficult to ventilate, because as I told you, oxygenation is the more important. Even if you cannot intubate, we can deal with that. We can bag the patient. We can put laryngeal mask airway. But what is worse if you cannot ventilate or oxygenate? Of course, you can have both together. How to assess the airway? We can assess the airway using the famous Malambati score. So ask the patient open mouth, tongue out, say ah, and according to how much you can see, this will reflect the grade of intubation. Also, there's other ways, the rule of 3-3-2, so 3 fingers, and if you can open the mouth and pass 3 fingers, and the mental hyoid 3 fingers, and the floor of the mouth to the cartilage is 2 fingers. There's also another way, and this is a picture to show. Also, the head movement and the neck movement and the atlanto-occipital joint also important to assess the airway. There's a nice score in a critically ill and in an emergency patient called Makoka score, and it's just factors related to the patient. For example, high Malambati score, if patient have obstructive sleep apnea, reduced cervical spinal mobility, or limited mouth opening. All of this get numbers, and according to if you calculate this will give you how much difficult. Also, if the patient have the pathology of patient is comatose or severe hypoxia, or the operator is non-anesthesiologist, all of them will have a score. Any score above 3 is difficult. So the total score is 12, but any score above 3 is difficult. This is, of course, an emergency situation. Okay. Now we talked about how to approach the airway with basic maneuvers, how to intubate, and how to assess for difficult intubation and difficult oxygenation. Now I'm going to tell you about the DAS. DAS is Difficult Airway Society in England, the Difficult Airway Society, the difficult intubation guidelines. The first plan, you need to have a plan, because if you don't have a plan when you approach the airway, you will lose the airway. And if you lose the airway, patient will die. So you need to have a plan in your head beforehand. So what's plan A? Plan A is to intubate the patient. So you ventilate the patient, so you bag the patient and then intubate the patient. If succeed, well and good, alhamdulillah, done. If you don't succeed, then you think about plan B. Plan B will put you try also to ventilate the patient and to try to insert laryngeal mask airway. don't be stuck with intubation trials. You have only 3 attempts of intubation. If you cannot, in these 3 attempts, you have to change your position, use bougie or something to improve your chances. But after 3, don't try the 4th. Go for supraglottic airway, which is a laryngeal mask airway. The laryngeal mask airway will just save the situation. Then final attempt of face mask. If you cannot, then you run into that very bad scenario of cannot intubate, cannot oxygenate. Then you have to do the surgical airway, which is the cricothyrotomy. Alhamdulillah, I have been now working more than 30 years. I never faced this because, alhamdulillah, if you follow this, very rarely you go into cannot intubate, cannot oxygen scenario. So you need to have a plan. Plan A is intubate. If failed, you oxygenate. If failed, this is the you go for the surgical airway or the emergency front of neck access. We call it now emergency front of neck access because the word surgical airway, I know it has been there for a long time, but they changed it now recently because it does not imply that you need a surgeon to do it. Anyone can do it because you save life by doing this, by doing emergency front of neck access. So now we have a plan. When you do intubation, you need also to prepare yourself. How to prepare yourself? You need personnel, qualified personnel to intubate. You need your medications and you need your equipment. So this is you need to have an intubation checklist. So you prepare your patient, you put your IV, you optimize the position, you assess the airway, you do pre-oxygenation, and you optimize the patient by giving fluid and inotropes. You prepare your equipment, so you need monitoring equipment, you need intubation equipment like tubes, laryngoscopes, bougie, suction, supraglottic airway, laryngeal masks, the nasal and oral airways, and phonoset. Then you prepare your drugs. You need to have your intubating drugs, especially ketamine, because if the patient is hypotensive, and you need to have your muscle relaxant. Also, you need to have resuscitation drugs like pressors and inotropes, and you need to also maintain sedation after intubation. You need to prepare your team leader, the intubator, the second help, the cricoid force, and the drugs, and who's doing manual alignment stabilization in case of head trauma, and who you will call for help. Don't think about when you are in trouble to call, because you need to, beforehand, you know who you will call, and you need to know the number. And then you prepare for difficulty, as I told you, plan A, plan B, plan C, and plan D, as I told you before. This is some examples of intubation equipment. There's laryngoscopes, the tubes, the stylet, the bougie, and this McGill forceps. This is the types of laryngoscopes, direct laryngoscopes, the Macintosh and Miller. Usually use Macintosh for adults, the one with the curved ones. McCoy laryngoscope is very important in difficult situations, especially if you don't have a video laryngoscope. And the McCoy laryngoscope is a modification of Macintosh laryngoscope. So what McCoy has done is to allow the put this lever, which will move the distal part of the laryngoscope blade. When you do this, you can convert a difficult intubation grade like grade 4 or 3 to a better grade, and you can intubate by doing this, because you can elevate the epiglottis. I find, and somebody say, if you have a McCoy and a bougie, you can intubate anyone. So I always have, if you have a difficult airway, always have with you McCoy laryngoscope and a bougie. And by this, I can guarantee to you, inshallah, you can intubate most of the patients. This is how to do with the bougie. So this bougie is when you cannot intubate with the tube itself, then you can use your laryngoscope. You can put the bougie as a guide or guide wire, and then you can railroad your tube on the. Some of the bougies even have a vented tip, which you can even give oxygen through. This is how to show how to the gum elastic bougie here. This anesthesiologist is intubating with the bougie. Notice this very important thing. This is called high flow nasal oxygen. Sometimes I know that in Gaza or in difficult, you might not have it, but at least have a nasal oxygen on the patient. Then you can intubate with the bougie. Then after that, you can railroad the tube. You can see here that the tube is railroad on the bougie. Then you can push the tube down and then remove the bougie. This is just to show you the difference, because some people will confuse between bougie and stylet. Stylet will be shorter and will never pass through the tube, but the bougie is longer and the tube will railroad on it. So this is the stylet here, for example, and this stylet is, you can see it will not pass through the tube. It's just, it helps to modify the shape of the tube, make it more angulated, but you cannot, but the bougie is different. Bougie, you intubate with the bougie, then you slide the tube on top. Laryngeal mask airway. This is the anesthetist friend and anyone friend who deal with airway. This is the best invention in the last 20-30 years. This can save a lot of lives. And this laryngeal mask airway, even if you don't have any airway skills, anyone can put it easily. And you can put it here in the back of the throat, and it will sit, and the opening will face the larynx, and you inflate the cuff, and you can ventilate through it. And you can use it as a tube until you can have somebody experienced who can put the tube for you. So this is another modification of the laryngeal mask airway called iGel. Doesn't need to inflate the cuff and is more stiff, so you can put it easily, and it's easier in insertion. This is how to do LMA, laryngeal mask airway insertion. Sometimes you need your finger in order to guide the LMA. Okay. Rapid sequence induction is the way we go with emergency intubation. So we talked about how you manage the airway, how to have a plan A, plan B, plan C, and we talked about plan B, how to put the laryngeal mask airway. We're finished with that. Now talk about rapid sequence induction. Rapid sequence induction is the standard approach in people who are in emergency situation. So you need to have the 7 P's. The 7 P's, you have to prepare your patient, you prepare equipment, the checklist I showed you before. You pre-oxygenate your patient for 5 minutes. You give pre-medication drugs. You give paralysis with induction. Then you position the patient. You place your tube. Then you do post-intubation management. And once you place your tube, you need to confirm the tube is in place. How we do this? By looking into the capnograph and by listening to the chest. But capnograph is a gold standard after seeing the tube with your own eyes passing through the vocal cords. And sometimes we have this color capnography, and when turned to yellow, yellow is yes. What happens if you have a poor bilateral breath sounds after intubation? This is a mnemonic called DOPE. Either the tube is displaced, not in the right place, or maybe obstructed, or maybe the patient have esophageal intubation or pneumothorax. This is the 7 P's, the classical 7 P's I told you about. You prepare your medication, you prepare your laryngoscope, everything, your equipment, your patient, you have a plan and monitors. Then you pre-oxygenate the patient, you optimize your patient, you protect and position the patient, you do cricoid pressure in order to prevent aspiration. It's not mandatory now, but sometimes we need to do it. Then you induce the patient with paralysis. You place the tube and you make a proof by capnography, then post-intubation management. Sometimes we can modify this standard or classic rapid sequence by doing pre-treatment, by sometimes removing our cricoid pressure. If it's difficult intubation, we can remove the cricoid pressure in order to improve the view, and then also the type of anesthetic can change to, for example, ketamine, which will have less cardiovascular depression effect. Also, sometimes we do bag and mask ventilation. Rapid sequence, standard rapid sequence, we don't bag the patient, but sometimes if the patient is hypoxic, you are allowed to do bag and mask if the patient is hypoxic after giving the medication. So we finish with this. We talk now about how to do the guidelines. We told you about the plan A to intubate. If you fail, you put supraglottic airway, which is the laryngeal mask airway. Then you final attempt of face mask. If you cannot, then you go in this scenario, which is the worst scenario. I'm going to tell you about the last scenario, which is plan D, because you need to know about this, because you can save lives. So the scalpel, the standard now, the DAS guideline is called scalpel cricothyrotomy. So now we don't use any set. What we need, we don't have a specific set for cricothyrotomy. What we need is 3 things. We need a scalpel, we need a bougie, we need a tube size 6. That's it. Any you can have it anywhere. So you need to have, as I told you, scalpel, a standard scalpel, bougie, and size 6 tube, and that's it. So how to do it? So of course, this cannot intubate, cannot oxygenate scenario is rare, unfamiliar, stressful. You have limited time. Sometimes you are unprepared. So you need to think, you need to be trained on this. You need to practice because it shouldn't be your first time when you do this. How can we know it? It's the anatomy is the cricothyroid membrane. So this is the thyroid cartilage. This is the cricoid cartilage. Then you feel the dip or the gap between both, and this is the this will be your cricothyroid membrane. This is I'll just show you in red. Then and it's the first line. As I told you, it's the fastest and the most reliable. There's a video about it. There's no time to show you the video, but at least this is what we do. So we feel here, we feel with it. We'll go with a scalpel, we'll do transverse incision, then we'll convert from transverse incision 90-degree into vertical incision. Then we'll put our bougie. Once you put our bougie, then we can slide the tube on top of the bougie. And this is by sliding the tube, you have an airway, a patent airway. Then you can ventilate the patient through the tube in the cricothyroid membrane. You can ventilate the patient with 100% oxygen. I'll just give you a one. This is a real life case, an airway case. A patient have injured and was burned as well. This a kerosene stove exploded, burned to the face and the chest. So this patient had no hemorrhage, but had facial swelling, and had the swelling is worse. They had a hoarse voice and stridor, and saturation start. Despite the saturation is not, it still have a good saturation, but it start to drop, and in burns as well. And we don't wait for them to be to collapse. We need to intubate early. So how we do this? We have to secure the airway. To assess quickly the airway by good mouth opening. If the patient is difficult, then we might think about awake intubation. But if the patient is not difficult, then we can do the plans, as I told you, plan A, plan B, plan C, and if you, inshallah, you not reach plan D, which I told you how to do, the emergency front of neck, the scalpel, and bougie and tube. This is in this patient, alhamdulillah, we managed to intubate. This is another patient we could not manage to intubate, and we did the emergency surgical airway. So in some people you cannot intubate, then you have to go for the front of neck access. So we finish now with the airway. We'll talk about breathing, or how to anesthetize this patient. This is an old anesthesia apparatus. This is, you don't see this in theaters or hospitals, because this is for the field. And it's no point to tell you about the fancy anesthetic machines. I'm talking about now in areas which are deprived areas, or you might not have anesthesia machine. So that one is used by military and by anesthetists in remote situation. It's called tri-service anesthesia apparatus. This has been there for a long time. It's called draw over vaporizers, but now it has been now we have a recent one, more recent one, which is better than this one. So this one is a bit old, it's not very reliable. So we now have this company from England called Diamedica, and we can buy this from them. It's not that expensive, and this does not, you don't need, you can use even on air or an oxygen cylinder, and doesn't need power, and doesn't need electricity. so you can use it anywhere. And it's portable. It comes in a bag, like a small suitcase, and you can carry with it anywhere. Only weigh 10 kilograms. This is the one. This anesthesia machine, and this is the vaporizer, a small vaporizer, which you can. This vaporizer can have halothane or isoflurane or sevoflurane in this small bag. It's very useful actually, and I would advise if we go to Gaza or anywhere to have it with us. As I told you, it weighs about 10 kilos, and it is lightweight, and can be taken in the aeroplane as a hand luggage. Then I'm going now to talk about how to provide anesthesia in a tent or field anesthesia in a place of war. Of course, in field anesthesia, you don't have the luxury of the OR and theater and everything, so you need to modify your technique. So you have limited monitoring, so you don't have the standard monitoring, so you have portable oxygen saturation, you have the manual blood pressure, so it's not the standard one. And also sometimes you need oxygen cylinders. You don't have a post-operative care and no ICU, so you need to also to work on this. You have also limited capacity. You have a lot of injured people in a very limited area. Sometimes we need even to go outside and leave people on the pavement. So you need to think about these things as well. So transfer also can be very difficult or impossible. Like this, we have a bomb here, so sometimes you cannot even move with the ambulance. So you have, if you cannot move with the ambulance, you are stuck. You will have to work in this tent or this remote area. You cannot go to the hospital, so you have to work there as anesthetist or surgeon. So if you do this field anesthesia, you only do emergency surgery. You don't do like fancy things there. You just do life-saving surgery only. Keep it simple. Avoid general anesthesia if possible, because if you run into general anesthesia, you might find you might run into complications. So try to do regional techniques. Try to do sedation. Don't do the full-blown general anesthesia. So avoid general anesthesia. For example, here we're giving a block. Here also we give a block or intravenous regional anesthesia. Here we do a spinal, and even we deliver a patient. We're done here cesarean section under spine. Of course, this is an emergency section. Vascular access. Vascular access, as we all know, we can start first of all with peripheral cannula. And we have different sizes of cannula. We all know this, different colors and different sizes. Or you need center line. Sometimes you need center line in order to give medications, special medications. But we don't usually do center lines unless we have to. Then you have the interosseous. Interosseous, why we need interosseous? If you cannot put cannula or you cannot put center line, sometimes you can run into this situation, especially in trauma. And this is the equipment for interosseous access. You need an introducer. It's like we call it is like a chenure, and you have the different sizes. You have longer. The yellow one is longer for about 45 millimeter, 4.5 centimeter. You have the blue 25, and you have the small one 15 millimeter, the pink one. You aspirate bone marrow, and you make sure that you are in the right place. Where are the bones we go for? Either the medial side of the tibia or the humerus head. So most people and most teaching go for the tibia, but actually now the new trend is to go for the humerus. Why? Because a lot of injuries can happen in the leg, amputation and things, so better to avoid. And also, when you have the humerus interosseous is near you, you are an anesthesiologist. Usually anesthesiologist is near the head. We deal with the airway. We're on the top of the patient. Interosseous in the leg will be far away from us, so better to have it near to us. So, and the flow rate, actually you can have a higher rate in the humerus. So when you use the humerus, you can have a maximum flow of 6 liters per hour, which is a very good. Imagine here the tibia is only 1 liter per hour. Of course, in either in humerus or tibia, you need to have a pressure bag. You cannot give the fluid without pressure bag in interosseous, either humerus or tibia. You have to have the fluid under pressure. And anything you can give it in peripheral, you can give it in interosseous. Any medication can be given. So there's no specific medication interosseous. Anything can be given. You can use it as a normal cannula. And and also one comment here that where you can use it the length. Somebody will ask me how long I can use interosseous. I would say to you 24 hours until you find a cannula or central line. We can push it up to 48 hours, but please don't use more than that. Otherwise, you can cause complications and osteomyelitis. Field anesthesia. What medication we use? Ketamine. Ketamine is the best in field anesthesia. There's no special storage. You don't need a refrigerator. There's no complex delivery system. You don't need like an infusion pump or anything. No, you don't need monitoring. So it's a very good medication which suits that area in a tent or a field anesthesia in the field. So it's versatile. You can give it through the IV, you can give it IM, subcutaneous, oral, rectal, nasal, epidural. You can give it anywhere. So it's very good. And it ranges from can cause analgesia, can give sedation, can give full anesthesia. So it starts from basic anesthesia to full anesthesia. It also have good characters like bronchodilator and inotropic effect. It has, of course, some disadvantages, but this advantage we can live with. It doesn't make the patient still. A patient can move around, have some salivation. Also, patient can take long time to recover, and some hallucination can happen. That's why sometimes we use midazolam with it. This is a real case which we use. This is like a 32 years old gunshot male has been gunshot in the abdomen, shocked, and no inotropes. And you can see here how much the shooting has caused his intestine to go out of his belly. So the best thing we use here, we use ketamine and just to mask, just make the patient ventilate through the mask. So sedation and ketamine IV. That's it. I don't give full anesthesia. So you can do rapid sequence, the one I just talked to you about. You can use ketamine to do rapid sequence, and you can use with it a small dose of atropine and midazolam. You can use the ketamine even in maintenance by intermittent bolusing. If you have infusion, you can run infusion. If you don't have infusion pump, you can put 500 milligram of ketamine in a 500 ml bag, and you can do that drops. You can do 1 to 2 drops per kg per minute. So, for example, in a patient like you can do 100 drops per minute. You can count the drops and make 100 drops per minute. Of course, if you can paralyze, but better if you don't intubate, don't paralyze, and you stop early, because if you leave till the end, patient will not wake up soon, because as I told you, it has delayed recovery. This is, even you can use it in children. This is a 9-month-old baby with a bite, animal bite to the head, distressed and agitated, and we can use a ketamine here with a small dose in order to sedate that child. Even we can give it IM. So here we couldn't, with the child, it's sometimes difficult to put the cannula, so we give it IM, and we maintain with IM boluses. Oral ketamine also is very useful, especially in analgesia and sedation. For example, this child has burn, and we can give that child, instead of stabbing that child with needles, we can give it oral. We can give it with paracetamol. So you can mix a mixture of paracetamol and ketamine and give it to the child. And also you can give midazolam also to sedate the child. And by this you can do burn dressings. Also, this is, you can give it as general anesthesia, and even you can give it with a you can combine spinal and IV sedation. So you can give spinal anesthesia and IV medication, ketamine as sedation. Also, for post-operative care, this patient, for example, had an operation in his abdomen, and we encourage the patient to sit up and do respiration exercise. Of course, we don't have incentive spirometry, so we give the patient glove in order to to inflate this glove and to help with the breathing. And this patient will not be able to do this because without ketamine, because he will have very painful, will be very painful for him. So when we give ketamine for anesthesia, a small dose will help him a lot in order to allow him to do this breathing exercises. Also, it can be used for neuropathic pain, especially for like this people, somebody have amputation and neuropathic pain. You can give it orally 3 times per day, 50 milligram, 3 times per day. It will help for 3 weeks. It will help a lot with neuropathic pain. There's a dogma or about giving ketamine in head injury, because in the old teaching they said don't give ketamine if the patient have head injury, but the reality, there's no evidence that ICP will rise with if you control the CO2 by ventilation. And it has a good effect because it maintains the cerebral perfusion pressure, and also can have a neuroprotective effect because of the NMDA receptor blockage, which can block the destructive intercellular mechanism of brain injury. So actually we use ketamine with head injury now. So in summary, field hospital anesthesia, sometimes we don't have enough electricity, oxygen monitoring, so we have to deal with what we have. Avoid general anesthesia if we can, and ketamine is very safe and very, very versatile drug. So thank you. This is my first lecture, and I'm going to follow up with a second lecture, which will be a very short lecture. So my second lecture is about regional anesthesia. Regional anesthesia, as we all know, when we don't give, a patient will be awake, and we give anesthesia to a certain part of the body. This certain part can be like half of the body, like spinal, or nearly half, like 3/4 of the body, like epidural. Or you can do infiltration anesthesia. You can do plexus block in the upper limb, like brachial plexus, or lower limb, like lumbar plexus or lumbosacral. Also, I'm going to talk about a very famous block now, which is a very versatile, which you can use in remote areas like war areas in Gaza, the rectospinal block, which is is a new block which we use now a lot and is very useful for these areas. Also, I'll go to touch about IV regional anesthesia and ankle block. Our life now is better when we have ultrasound to see where we go with the needle. Of course, sometimes in these areas you don't have an ultrasound machine, but if you go there, and if Allah subhanahu wa ta'ala allow us to go there, we can buy one of them. This machine is ultrasound, this handheld, and there's not there's one with a wire here, so you have to connect, and this one is wireless. So this might be a bit more expensive, but either wired or wireless, you can connect to your mobile, your smartphone, and you can actually use it as an ultrasound machine. It's very useful, and it will help you a lot with blocks. So it's very useful. I advise any one of us who will go to buy this and will take it with him. So this is, as I told you, this is the ectospiny plane block. Is a very easy block, and is versatile, is very good block to learn, and you don't need a high skill to do it. So it's very suitable to our to the purpose of our job there. So this is the anatomy. Ectospine is a group of muscles which stretch from the back, back of the neck up there from the nuchal line till all the way down to the sacrum. So you can see here is from all of this. So it passes to behind the neck, behind the chest, and behind the lumbar and sacral region. So how to do it? Easy, very easy, very easy. What you do, you get your needle, you feel the transverse process. Once you hit the transverse process on the edge, you inject the local anesthesia. That's it. So, but the question is how to see the transverse process. You can do it blindly, so you can do you can feel the spinous process of the patient. So you feel the spinous process of the vertebral column, and you move your hand about 2 centimeters lateral from the midline, and you can feel this will be your transverse process. You go with the needle, you hit the transverse process, and this will be your transverse process. You can do it blind. But I advise you, if you can use ultrasound, as I told you, the handheld, then you can see the planes better, and you can see the transverse process easier. Once you see transverse process, this is the transverse process. So this is the spinous process, as I told you, about 2 centimeters from the spinous process. Once you hit that, you inject, and this is the plane. So this is the ectospiny muscle. This will be the ectospiny muscle, and this will be the plane you inject, the green area. And you can see here the spinal nerve coming. This is the ventral and the dorsal rami. And when you inject here, it will spread up and down, medial and lateral. And it's a very good block. It is a volume block. You have to give good volume, at least 30 mils. When you give 30 mils in a thoracic lesion, you cover 4 levels up, 4 levels down, so total of 8 levels. In a lumbar region, you will cover about 4 levels, 2 levels up, 2 levels down. Somebody will ask me, can I give bilateral? Yes, you can give. But of course, you have to calculate the dose. Don't exceed the maximum toxic dose. Don't go onto toxic level. So you need to dilute your local anesthesia. The indications, anywhere, any operation anywhere. For example, if you have abdominal operation, you can give it at the level of T10. If you have a lumbar operation or something in the back, you can give it in the level of L3, and here you give bilateral. If you have a chest operation like breast surgery or something in the ribs, you can give in the T5 area. So as I told you, indication can be anywhere from the neck, from the chest, for breast, abdomen, lumbar, and sacral. Okay, so this block, as I told you, very good ectospinal block. The next block, which is also very easy, you can do it also very easy blind, is the intercostal block. So how to do intercostal block? You set the patient up, you feel the spinous processes, then you feel the ribs, and you go about between 7 to 10 centimeters lateral to the spinous process. You feel the ribs, and you go below the edge of the rib. Because as we all know, the neurovascular bundle of the rib is below the edge of the rib. So this will be the neurovascular bundle. You go with your needle. It is very superficial. You just pass. So you hit the bone. You just pass the bone. And now you aspirate. Make sure there's no blood coming. Then you inject your local anesthesia. You can inject about between 2 to 3 mils in each level. So, and you can do like as many levels as you want. You can do 5, 6 levels in order to cover the area you want to cover. For example, in breast surgery, I would cover between maybe rib 4 to rib 8 or something. Okay, another block, but this block actually needs the ultrasound. It's called transversus abdominis plane block, or sometimes we call it TAB block as an abbreviation. And what we do, we inject our local anesthesia between this EO is external oblique, IO is internal oblique, TA is transversus abdominis, and then we give our local anesthesia here between the internal oblique and transverse abdominis. And by this, you can cover most of abdominal procedures. This is the subcutaneous tissue. This is ultrasound picture, of course. Subcutaneous tissue, external oblique, internal oblique, transversus abdominis, and you give here, and this is this plane between the internal and transverse. And this here, you can see here between the internal, you can see with this blue, you can see here the local is separating the internal oblique and transversus. This will, all the nerves are here, and when you give the local, you can block the abdominal nerves. By the way, it's also a volume block, so you need to give a lot of volume. You give at least 30 mils. Epidural spinal, we all know, there's not much to talk about. We know the difference between the epidural spinal. This is just show the anatomy. So spinal, you go into the CSF will come back, and it's more solid block, and you can do a lot of procedure in the lower half of body, including cesarean section of the spinal. Epidural, you can put epidural abdominal, even thoracic, so you can cover more wider areas. This epidural, you can put a catheter, but I wouldn't advise you in these areas to put a catheter. I would use only single epidural block. if you want, because putting a catheter, you can run into problems of infection. Also, you don't have infusion pumps. So I don't advise you unless you have the facilities to do epidural catheter infusion. Last a few slides now about regional anesthesia. This is an old technique invented by Bayer Block. So you inject your local anesthesia, brilocaine or lidocaine, a small dose, and you inflate the cuff, and you can work on either the upper limb or lower limb. So this picture shows you the upper limb, but also you can do it in the leg. But you need to inflate the tourniquet above the systolic pressure. Otherwise, the local anesthesia can go into the systemic circulation. So you need to put the tourniquet above the systolic pressure. And even if the surgeon finishes early, you have to wait at least 20 minutes to half an hour before you can release the tourniquet. Plexus blocks for the upper limb and for the lower limb. So the upper limb, the brachial plexus block, the famous interscalene, supraclavicular, interclavicular, and axillary. You cannot do all of this. You can do either an interscalene if you are expert. Interscalene, you need to have done it many times before. Because you need to feel the sternocleidomastoid. You ask a patient to look to the other side. You feel then behind the sternocleidomastoid, you feel for the anterior scalene and the middle scalene, and your injection between the anterior and the middle scalene. This is how to do it with your both hands. Usually, if you do this and the patient awake, he will feel the tingling. He will not like this. So you know that you're on the right place. Where you put your needle at the level of the cricoid pressure. Cricoid cartilage at the level of C6, at the level of cricoid cartilage. This is where you put your needle. And the direction will be the needle has to be inserted in a slight caudal and posteromedial direction. Okay, axillary block is more easier for inexperienced people because it has a very good landmark, which is the axillary artery. So what you do, you ask the patient to put the hand like this. 90 degrees, then you go onto the lateral border of the pectoralis major muscle, and you feel for the axillary artery. Once you feel for the axillary artery, you follow the axillary artery to the lateral border of the pectoralis major, and you insert your needle. Some people actually go through the artery and aspirate blood and make sure that they are there, and then you inject superior and inferior to the artery, and by doing this very easy, you can do the block, axillary block, and you can anesthetize the whole of the arm, but not the shoulder, from forearm, the arm and forearm, and even to the hand by axillary block. But just make sure that you inject a good volume of local anesthesia, at least 30 to 40 minutes. This is upper limb. What about lower limb? This is the lumbar plexus block, femoral nerve. So the femoral nerve, as we all know, runs lateral to the artery, femoral artery. So this is anterior superior iliac spine, and this is inguinal ligaments, and this you feel for the femoral artery, and you go just lateral to the femoral artery. Actually, you don't actually go into the actual inguinal ligament. You go into something called inguinal crease. The crease is the junction between your thigh and your abdomen. So because the inguinal ligament itself is higher, so you go in the inguinal crease. And actually, in the inguinal crease, the block at the inguinal crease is better than if you block it there. So better to inject at the inguinal crease, which is about 4 to 6 centimeters below the inguinal ligament. And just to show you that when you inject in the inguinal crease, you have more likely 71% you have a good block. If you go in the inguinal ligament, your block will not be very good. So better go in the inguinal crease, and you have to be adjacent to the femoral artery. Don't go far away. You have to be adjacent to the femoral artery in order to have a good block. This is the area will block, so all the anterior part of the thigh. I would advise you also to put your hand and to block down below the femoral in order to make fascia iliaca block, or we call it 3-in-1 block. So you can block the whole lumbar plexus, including the lateral cutaneous nerve of the thigh and the obturator nerve. If you do this, you have a better block. What about sciatic nerve? This is I choose. There's many approaches, but choose this is the easiest. You can do it also blind. You feel for the greater trochanter and for the posterior superior iliac spine. Then you go to the middle, exactly the middle of that line, and you draw a perpendicular line 4 centimeter distal to that. This will be your point of injection. And by doing this, you can actually block the whole back of the leg, including the foot. What about ankle block? Ankle block is very easy. Anyone can do it. You have 5 injections. It's more like an infiltration block. You go in front of the medial malleolus and in front of the lateral malleolus and behind them. So and in the middle here and the anterior tibial artery also inject. So one here, one in front of the medial malleolus, one in behind, one in front of the lateral, one behind, and one in here in the next to the dorsalis pedis artery. And you can block the whole ankle for a lot of procedure in the ankle. By this, I finish, and I hope you, alhamdulillah, I stick to my time, and I hope you have benefit for the lecture, and I'm happy to answer any questions. Assalamu alaikum.
عليكم السلام ورحمة الله. Thank you so much, Yaser. MashaAllah. Thank you so much.
MashaAllah, Professor Yaser, that was very informative, practical, and stepwise fashion. It was a privilege listening to your lectures. May Allah benefit you and make it benefit to the people in Palestine and worldwide, inshallah. Over to you, Professor Muhammad.
Thank you, my dear brother, Dr. Ahmed. Thank you, my dear brother, Professor Yaser, for this very informative, rich, heavy meal. Really, for me, actually, I got a lot of new information. Thank you so much. My request to you, Yaser, if possible, can you think or consider making a virtual course about regional anesthesia? Because really, you are a great teacher. Thank you, Yaser. Thank you so much.
Allah khalid.
Assalamu alaikum.
Professor Muhammad, this is
عليكم السلام ورحمة الله. أهلا وسهلا. أهلا وسهلا.
يعني I appreciate your great effort, Dr. Yusuf, and I welcome much more welcome to Dr. Yaser Tolba, my friend.
حبيبي ازيك يا ابو حميد؟ وحشنا محمد.
We were working together 15 years ago in King Faisal Hospital in Riyadh.
ما شاء الله ما شاء الله.
One of the pioneers in anesthesia, and I honor working with him for a couple of months, or I think longer than that.
ما شاء الله.
He's one of the
أستاذ كبير يا محمد. أنت بروفيسور كبير يا محمد. ما شاء الله.
Thank you very much, Dr. Yaser, and this is very good effort to trying to summarize all about general and regional anesthesia. This is very hard for any anesthetist to summarize or to give all of these informations in 40 or 50 minutes. Yeah, I appreciate your effort. Thank you very much. I think the message is to the most important, I think, is to teach a lot how to perform simple regional techniques, because it will help relieving pain and to do minor procedures or even moderate surgical procedures with the regional techniques, simple regional techniques. Even paramedics can do it, and instead of doing nothing.
Yes, I totally agree with you, Dr. Muhammad, and I will share a one's experience more than 30 years ago when I was young. I had in our department in Qasr Al Aini a difficult patient of thyrocardia, and our colleagues, the anesthetists, refused to give him anesthesia. I, with one of the anesthetists, arranged for a regional anesthesia, and I have done a thyroidectomy for thyrotoxicosis for this patient, and he went wonderful. So I'm sure that, as you said, regional and infiltration anesthesia is a key for performing surgeries in low resource settings. Thank you so much.